Hello, everyone, and happy American College of Cardiology Scientific Sessions Week. Whether you're joining us from the West Coast or the East Coast, good morning or good afternoon, we're glad to have you here. My name is Ryan Googe, and I am the Executive Director of the Partnership to Advance Cardiovascular Health, which we call PATCH for short. PATCH is a stakeholder coalition of a number of patient and provider organizations that work together on policy issues that impact appropriate access to patient care. I want to mention that membership to PATCH is free, and as long as you are a stakeholder organization interested in public policy that affects patients with heart disease, we would be honored to have your perspective included in our coalition. Every year, PATCH hosts a program at the ACC Scientific Sessions and an end-of-year meeting at the American Heart Association Scientific Sessions. Unfortunately, we can't have this event in person this year. Normally at ACC, we're running around with a video camera, getting clinician and patient testimonials and making great videos. And frankly, I miss that a lot, but we're grateful that in place of that, we can at least host this discussion. And for making this discussion possible, we want to thank two of our sponsors specifically, Amgen and Novartis, for generously supporting today's discussion. I also want to thank two PATCH members, the American Society for Preventive Cardiology and the Preventive Cardiovascular Nurses Association, for providing their thoughts, and clinicians, frankly, for this important webinar. And of course, thank you to our speakers, who I'll introduce shortly, and a couple of whom are members of ASPC and PCNA. Today, we're going to talk about how two things are linked: continuity of care and the prevention of heart attacks and strokes. Now, continuity of care is a buzzy term that has certainly been used frequently over the last 18 months as the world has dealt with the coronavirus pandemic. We often think, I think, of bridges between physical doctor's appointments via telemedicine when we're thinking about solutions to disrupted care, talking about continuity of care. But ensuring care is not disrupted and adhered to is a problem for cardiovascular patients, and it was a problem even before the world plunged into the COVID-19 pandemic. When talking about prevention in cardiovascular medicine, it's important to differentiate between primary and secondary prevention. Primary prevention is normally what people think of when they hear the word prevention, preventing that first heart attack. Frankly, primary prevention can be an overwhelming topic. A lot of times we're talking about changing the diet, the exercise, the life patterns of millions of people a year in an increasingly sedentary country that is famous for its poor diet and exercise patterns. And that sometimes can feel impossible. But a question we want to ask today is, what if we knew who the most at-risk population of patients were, and we were able to target those people to decrease their risk? The irony is, we do know who those people are. They're the people who have already suffered a cardiovascular event. Some statistics. Someone has a heart attack in the United States roughly every 40 seconds. 800,000 people suffer a heart attack every year. What is shocking is that each year there are roughly 335,000 recurrent heart attacks. And of the 800,000 people a year who suffer a heart attack, 1 in 5 will suffer another event within 5 years. When our understanding of cardiovascular disease and our means to treat it increase every single year, one has to ask, why is this happening? So to help answer that question, we're going to explore continuity of care. And by that, today, we mean the path a patient takes after having his or her first heart attack or stroke. Where are the bumps in the road? Are there specific points in a patient's post-event heart journey where care is disrupted or a patient becomes confused, where therapy is abandoned, or where suboptimal care is introduced? Today, we're going to seek out some answers to those questions by talking with someone who has suffered a massive heart attack. We'll also talk to some clinicians about their experiences with patients, and hopefully we'll be able to discuss how we can do better. Today, you'll hear from Chad Witheridge, a patient with genetically high cholesterol who suffered a massive heart attack. And on the clinician side, we'll hear from Shah, an ER doctor from Chicago, Illinois. We'll also hear from a nurse practitioner, Lisa Maher, from Waterloo, Iowa. And to wrap things up, we'll be chatting with two cardiologists who have been on the front lines of patient care for years, Doctors Seth Baum and Dharmesh Patel. To get us started, I would like to introduce the person who keeps the trains running on time here at Patch, our Director of Policy and Outreach, Jasmine Patel. She'll be managing our first two panels, and I'll be back at the end to wrap up our final discussion. Jasmine?
Thank you, Ryan and Chad. Welcome, Chad. It's so great to see you. So for everyone who's watching us, Chad is a small business owner from Port Townsend, Washington. And as Ryan said, he suffered a massive heart attack 2 years ago. So let's get into this story. So Chad, did you ever think you were going to suffer a heart attack?
No, I'm 36 years old, 3 young daughters, fairly fit business owner. I was a select soccer coach. Never thought it would happen to me. I was aware of my family history, heart issues, but still never thought it was going to happen to me. My grandfather had an aortic valve replaced and a triple bypass. My uncle had a heart attack at 40, and things still didn't click. And my mother also has issues with lipid numbers, and not a thought that was going to happen at 36 years old.
So it's a family affair.
Yes.
So did you have any symptoms that, gave you a sign that, I have some cardiovascular things wrong with me? Tell us about the day you had your heart attack. What exactly happened?
So I was running a soccer tournament, 200 kids and adults. In the morning, I was pounding T-posts into the ground, running around, answering questions, making sure everything was going smoothly with our team. It was all great. Everything was good. I started to get some back pain. I didn't think much of it, just thought it was from the exertion in the morning. The next hour or so, it started getting worse, and I started becoming nauseous. Anxiety levels were rising. At that point, I just thought it was the 3 cups of coffee without having breakfast, but the feeling started getting worse, and I started to feel faint. My friend, Lieutenant Firefighter, I asked him to bring me to the fire station to get checked out to see what was happening. And at that point, they told me I was having a heart attack, and we were upgraded to ALS with a STEMI heart attack, and we were on our way to the hospital.
Wow. So as soon as you got into the ER, what happened next? Did you immediately go to get a cath lab done, or were there several steps in between that?
So I was in the ER for about 30 to 40 minutes. They were prepping the cath lab. There was somebody in there before me, so it took a little bit of time. Felt like an eternity. My wife was able to get there in time before I went in there. At that point, all I was thinking about was, am I going to see my girls again? It was quite stressful and an emotional time. We still talk about it a lot, and it's good to talk about. It was stressful for sure.
And how many days were you in the hospital, Chad?
I was in the hospital for 6 days. I had 2 stents placed the first day, and then additional 2 on the 4th day. I was in there on the 3rd day to get the additional stents, but another STEMI heart attack was coming in, so they actually had to pull me off the table after everything was prepped, and they said you have to wait for an additional day to get those 2 additional stents. So that's why I was in the hospital for longer. I had 2 stents in the right coronary and 2 in the left circumflex.
Now, were you diagnosed in the hospital? Like, were you diagnosed with familial hypercholesterolemia, or how did you come to that diagnosis?
So I didn't come to the diagnosis until I was referred to my lipid doctor from my cardiologist. But I do remember a point right after my first 2 stents when the cardiologist came in and said, you're probably going to have to be on this really expensive injection medication. And my head started spinning. I, at that point, was still kind of loopy a little bit with the medications for my back pain. There was definitely a lot to take in, and with all the buzzing around with the nurses and the doctors, I didn't really think about anything. At that point, I kind of knew there was some genetic stuff going on, obviously with my history, and I did know that. But when he did come in and said, you're going to have to be on an injection for the rest of your life, it kind of hit me hard.
Yeah, so I want to get into that a little bit. Tell us about what was going through your head post ER visit. You had to come to grips with this new reality. And I'm sure not only did this take an impact on you just trying to realize that you had just experienced a heart attack, but I'm sure mentally, it was challenging. So can you just expand on that a little bit?
Yeah, so I mean, really, right after I got out of the cath lab, all I could think about is I'm here. I want to see my children. When am I going to see my children? The thought of death was in the back of my mind, but not overwhelming. I was very relaxed due to the medications from the pain after the stents. I had faith in the team of doctors and nurses that were taking care of me. I'm a very busy person. Many questions were racing through my mind of why did this happen to me? I was ready to get back to work. It didn't really sink in till the second or third day that this was going to be a marathon, not a sprint. And with my mentality, that was a struggle. It was very emotional, 6 days in the hospital, very overwhelming at times, but at the same time, feeling of comfort and a newfound sense of purpose in life.
So you talked about how you had faith in all the doctors who were there treating you. When you were discharged from the ER, did you feel like you had a game plan that you were informed of? Did you know what to do next?
Yeah, we felt, me and my wife, we felt there was a game plan. I'm glad she was there to take the notes and to understand things, as my mind was just spinning like crazy still. It was clear for us. Schedule up with my cardiologist and stayed on track with everything that we were told during the hospital stay. We met with a dietitian before I left and discussed a plan moving forward. And that plan is still ever changing with everything. Even a plan is easier said than done, but with the support determination, we definitely made it happen.
So while you were in the hospital, who was your point of contact there that kind of just guided you through the entire process?
I would say is my cardiologist. He was there every day checking on me. I'm really grateful for him. My initial cardiologist, or the guy that placed the first 2 stents, I got to speak to him a little bit, but then he went on vacation, or his route or routine changed. So when I met the second cardiologist for my second set of stents, I told him, I said, "You're going to be my cardiologist because you've been the one there for me the most." My wife definitely played a role in that as well, just helping me out and, trying to figure out the right plan for us. My cardiologist was the prescriber of all the initial medications. He's the one who referred me to the cardiac rehab.
Okay. I just want to pause for a second. So we have Chad for 7 more minutes. To our audience watching, this is your time to ask questions and I will incorporate them. So Chad, the cardiologist that you saw at the ER, then that individual became your cardiologist you see now?
Yes.
Okay, great. So, on the course of this new reality, you mentioned you were prescribed medications and possibly, you were prescribed an injectable medication to reduce your LDL further. So did you have any issues getting on the medication that was prescribed to you at the ER? Were there any insurance hurdles, any cost barriers? Can you share about that?
Everything was fairly smooth. There was a little bit of a gap between the Repatha. So my first lipid appointment was in June. I had a follow-up in July, and my first injection was in August. And that might be fairly common. It definitely helped that I was already on the Lipitor, and I was on, or still am on, Plavix, lisinopril, metoprolol, baby aspirin, and then the Lipitor of 80 milligrams. So that helped me get on track to start lowering the LDL levels. But Repatha is what truly elevated or lowered it as much as it did.
And did you feel like you had developed a kind of a relationship with your cardiologist where it was this shared decision-making model that you guys openly discussed the options? He educated you about what the best guidelines say to do. Can you share about that? Or were you just in listening mode?
So I did a lot of listening, but I'm a talker. I'm a salesman. I'm a businessman. I don't just sit back. I want to take advantage of the opportunity. And we became really good friends on a professional level. Emails back and forth to each other, wanting to follow up. And as I started to do research on my history and the FH disease that I have, I started asking even more questions, and that just started growing into even a stronger relationship. And now I've started my website and my blog, and things are progressing. And every time I see him, he's got a smile on his face. He's happy to see me. I'm happy to see him. There's no stress involved, and it's a good relationship with my cardiologist.
That's great. There definitely shouldn't be stress involved. So today you see different doctors. You mentioned earlier that you also were talking to a lipidologist. So give us a breakdown of kind of your schedule in seeing different doctors throughout the year. Who exactly are they? What specialty are they? And how many times a year do you see each of them?
So now it's just in person annually, my cardiologist, with the exception of the phone calls and emails if I have simple questions. And then my lipid endocrinology doctor as well out of University of Washington. We are also on an annual basis now. They're so happy with my results. My LDL was over 400 at my heart attack, and it's now down to 35 with the Repatha and the other medications that I'm on, as well as Lipitor.
And do they all communicate with each other? Or who's the point of contact on, when aligning everybody on all the medications you're on?
Yeah, so we have my chart. They're all able to log in and see that information. Also, my primary care provider in my hometown, I talk to him on an annual basis. And I wouldn't say there's one main point of contact. Each one of them plays their own role in how we're taking care of me. And I appreciate every one of them for that.
So the health system that you're in now, is there a patient navigator system for you to just log into, keep track of your results, keep track of your medication, ask the hospital system questions?
Yeah, so that is with my chart. I'm able to log in and it lists my medications. If there is something needs to be tweaked, I was on metoprolol tartrate twice a day, and that was kind of messing with me in the evening. So I went to a succinate metoprolol, 50 milligrams, and that was smooth transition.
Okay, great. And so would you say that you're pretty diligent about keeping track of everything that you're on?
Yeah, I have not missed one medication since my heart attack.
That's great to hear. So there's a question in the chat, and it actually relates to my final question for you. So what advice can you give somebody who kind of was in your shoes 2 years ago? They didn't even know that they were at risk for heart disease. They had just experienced a heart attack and they're lost and they don't know what to do next. So what is your advice to that person?
Okay, yeah. First of all, I'd like to thank Patch and everyone on this call for the opportunity to share my story. In this fight, we're all in it together. To others who have experienced an event like mine, I say, don't live your life in fear. Listen to your doctors. Seek comfort in the other cardiac patients and forums specific to your condition. Be your strongest advocate. I'm always available to listen to your heart story. I enjoy sharing mine as well as listening to others. We're all unique in that way. And always thank you for a healthy heart. Thank you very much.
Thanks, Chad. So one final question. I just am curious to know. So you're diagnosed with FH. Do any of your children have high cholesterol?
Yes. So my youngest daughter has been diagnosed with FH. She's 9 years old and her LDL is at 190. Our second oldest daughter, she's 12. She's right at borderline, but has not been diagnosed yet.
Right. Well, the good thing is they have it, you know what to do, and hopefully they will never deal with a heart attack in their life. So Thank you, Chad, so much for your time. If you'd like to learn more about Chad's story, he has a website where he has many blog posts. It's very interesting. His website is myheartmission.com. Thank you so much, Chad. So now I'm going to welcome Dr. Lisa Maher and Dr. Sapana Shah. Dr. Maher is a nurse practitioner at Cedar Valley Cardiovascular Center in Waterloo, Iowa. She specializes in cardiology, sleep apnea, weight loss, and risk factor modification. And Dr. Shah is an emergency medicine physician at North Shore University Health System in Chicago, Illinois. Welcome both. I'm so excited you're here. So would you say that Chad's story is an example of success? And if so, what do you find encouraging about his example in particular?
Yeah,
I will start with Dr. Maher. Yeah, go ahead.
Thanks. I'll go ahead and start. Yeah, I think his story is definitely a story of success. He recognized symptoms and he was able to get the help and be transferred to a facility that could not only diagnose him, but then treat him properly. He is also successful throughout his hospital stay. He was started on the appropriate medications and then has transitioned to developing a trusting relationship with both his cardiologist and his lipidologist. So the fact that he has gotten on the medications, that he's continuing to take these appropriately, that he said he hasn't missed any doses of his medications, the fact that he continues to follow up, and then also the fact that he continues to educate others is so important.
Absolutely. Dr. Shah, any comments there?
I agree completely with Dr. Maher. I think that Chad is an ideal patient and was in an ideal situation where he received the help and followed through with what he had to do as a patient as well. And the hospital system seemed to work out great for him. So he's a lesson for all of us to follow.
Absolutely. So Dr. Shah, can you tell us about your work and how many patients come into the ER, at least during your shift, with a heart attack?
So I cover a busy suburban hospital system of 4 hospitals, and I would probably see about anywhere from 0 to 5 heart patients per week, and even more so with just the symptom of chest pain, but probably 0 to 5 that go on to have an acute coronary event.
And do you ever see repeat patients?
I do see repeat patients. They're not necessarily patients that I have seen and diagnosed with a coronary event that come back to me again because I am in the ER. But I do see patients that may have had an event, a month ago and then are back now seeing me as a new provider.
Got it. Okay. So this question is for you as well, Dr. Shah. Let's take Chad's story as an example. So someone comes into the hospital with heart attack symptoms, and likely they need an intervention. So what are the general steps for somebody like Chad, who just had a heart attack and is admitted into the ER? What is their journey?
So Chad was in a situation where he received help from his firefighter friend. Most of the general public is either going to drive in themselves or call 911. If 911 is initiated and they do a EKG that shows any signs of coronary event, then they're going to relay that to us in the ER. So we get it before the patient even arrives, and we can initiate the entire cardiac team. If the patient drives in, they get complaint of chest pain and they get an immediate EKG in triage. And if there's anything noted on that, we can also initiate it. So the first step is seeing that there is a coronary event happening, and then we initiate a code that enlists the help of the cardiac cath team. The cardiologist calls down or comes down immediately, and our goal is to get this patient to the cath lab as soon as possible.
Got it. Okay. So how many different clinicians do you think somebody who comes in with a heart attack sees during their ER stay? So Chad, for example, he stayed in the hospital for multiple days. You yourself, you do shifts in and out of the hospital, and I'm sure a lot of these other doctors do. So can you talk about that a little bit more?
So from the ER visit to inpatient and through their cardiac event, I would say anywhere from 8 to 10 clinicians, nurse practitioners, dietitians, physicians. Yeah, I would say at least 8 to 10 minimum.
Okay. That's a lot of doctors for one patient to see, and I'm sure it can be extremely confusing. But Chad seemed to have a grip of his entire hospital stay visit. But I'm sure for most patients seems like that's not the case. They're more lost than Chad maybe. So when we think of cardiovascular disease patients these days, we know that patients are actually experiencing cardiovascular events younger. They have FH, they have comorbidities, especially. And so, sometimes there can be so many variables when it comes to managing this kind of patient. So in the case for this kind of patient, what is the step there when they have so many things that are impacting their health? I guess I'll ask you, Dr. Maher, and then Dr. Shah, if you have any comments on that, please chime in.
Yeah, there's so many steps involved, and there's so many different points of care that they have throughout this hospitalization. It's important just that they establish a trusting relationship. It's important that everyone is on the same page as far as connecting that point of care, and then establishing long-term follow-up is so important with those patients.
Dr. Shah, any comments?
I would chime in that I think that, like Chad, a advocate for the patient, because the patient sometimes has so many pieces of information coming at them, in addition to actual clinicians, nurses coming in and checking up on them, that having somebody that is a point of contact that's going to, like Chad's wife, take notes and ask the questions that maybe the patient is not currently thinking about, just with everything else going on. So a patient advocate that is easily accessible, I think, is important.
So is it up to the patient to then communicate this entire experience back to the primary care physician, or is the doctor who saw them at the ER responsible for that? Let's start with you, Dr. Shah.
So generally, the patient, a cardiac event patient, is not in the emergency room for very long, hopefully.
Yeah.
And then once they are post cardiac cath and inpatient, then generally it becomes well, basically it's a many people coming in and telling this patient what they need to do, what the follow-up would be. And so really it's a matter of having good notes and good follow-up care afterwards.
Sure. Okay. Well, you know what? I'm actually going to pivot to a follow-up question. So Dr. Maher, where do preventive cardiovascular nurse practitioners fit in this journey then, where the patient is being handed off to so many different clinicians?
Yeah. So in my practice, I see both the round on patients in the hospital, but also after their post-hospital stay. So sometimes I will have these patients that present, instead of an acute event, present with chest pain as an outpatient, and we can start their workup from there, which can follow a stress test or an echocardiogram and some basic lab work. If they do not, present as an acute event, but they do have an example would be FH or underlying risk factors, that's when we really focus on treating those risk factors, whether they're diabetic, whether their cholesterol is high, looking at their family history, and really assessing those risk factors. So the preventative nurse practitioner can fit in really at any point of care, at any time throughout anyone's stay, and continue to focus on modifying those risk factors. So whether it's prior to an event, or hopefully preventing an event at that point, or seeing them after, and then arranging care for follow-up of who's going to manage their diabetes, who's going to manage their lipids, and just in general their cardiac care. So there's many points where someone like me, for example, could come in and see the patient, and then hopefully be the piece that ties that all together.
So Lisa, what do you find is the most difficult part of coordinating care for patients post cardiovascular event? This is a question from an audience member.
Yeah, I think a lot of it is really trying to figure out who's going to manage what piece. We, in my practice, we love primary care because they're the glue that really holds everything together. There's also maybe some conflict in that who is responsible to manage the diabetes with these new crossover with the cardiovascular risk reduction and diabetes, or who's responsible for managing the lipids. I think that if cardiology and primary care has a good working relationship and puts the patient's best interest in mind, then I think that can be a seamless transition. But I also can foresee that there can be a lot of bumps in the road purely because not all groups are as cohesive. Not all communication gets sent back and forth. Not all medical records are shared within the same system. So sometimes when they get transferred around from person to person, it does make it more difficult. Chad was very lucky, and I agree with Dr. Shah that he was very lucky to have his wife involved in his care, who could take those additional notes and be an advocate for him. But also Chad has that personality that he was an advocate for himself, which is wonderful. Sometimes when we get these older patients, 70s, 80s, who don't have family or friends living nearby, sometimes that can be very difficult to manage.
Absolutely. Okay, so Dr. Maher, we were talking to many of your colleagues about what kinds of questions we should be asking during this webinar, and cardiac rehab was just a common theme. So let's talk about cardiac rehab. What is it? What happens at cardiac rehab, and why is it so important for a patient who just experienced a heart attack?
You bet. So cardiac rehab comes in 3 different phases. The phase 1 is when the patient is in the hospital, is when they are still an inpatient. So Chad, after his first event, probably met some of the cardiac rehab nurses initially during his hospital stay. At that point, they're responsible for just talking with the patient, looking at their risk factors, getting the patient out of bed, and making sure that they feel comfortable moving and walking around the unit before being discharged home. Phase 2 comes in where the patient has been discharged and then goes back in as an outpatient 2 to 3 days per week to focus on exercise and advancing that exercise tolerance. This is a monitored session. So the patient is hooked up and monitored throughout the session. So their heart rate is recorded, their rhythm is recorded, and vitals are also measured. I love this phase of cardiac rehab because those cardiac rehab nurses and providers are seeing the patient 2 to 3 times a week, which is so important initially. It's kind of that extra point of care. They have eyes on the patient. They can give the primary cardiologist or primary care office a call if there is anything concerning. They really get comfortable with that patient, and in turn, the patient really gets comfortable with them to share anything. It's a good point too, because not only are they there in therapy 2 to 3 days a week, but these nurses also encourage them to go above and beyond that to that recommended 5 to 7 days of activity and advance it slowly, but at a good pace for the patient so they can continue to progress their exercise tolerance. Some of these patients have never worked out a day in their life. Some have never been on a treadmill or any type of exercise bike or recumbent bike. Some have never lifted any weights or resistance bands. So this phase is extremely important. And then lastly, after they complete up to 12 weeks or 36 sessions, depending on what insurance would allow, they can go into more of a phase 3 or a healthy living phase. This is usually a pay out of pocket, so not covered by insurance, where phase 1 and phase 2 are mostly covered by insurance. So phase 3 is usually a pay out of pocket session, but can encourage the patient to continue to work with that team and continue to build healthy relationships. During most cardiac rehabs too, during that phase 2, they meet with a dietitian. They meet with someone to talk about their lipids. They'll meet with a pharmacist to talk about their medications. So they gain access to a lot of different providers during that time too.
So it sounds like this is, in fact, the most important part of continuing prevention for another cardiovascular event. So I want to ask you about accessibility here. We know that, Medicare, for example, the patients who are 65 and older, they can qualify and insurance will pay for a portion of cardiac rehab. But, I said earlier, there are more and more patients who are dealing with heart attacks at much younger ages. So for those patients, are there a lot of insurance hurdles in place for them?
I think each plan is so different. A lot of the cardiac rehab programs around my area are good, and they will be upfront with the patient as right away. They will call before bringing that patient in and say, your plan will cover this much, or your plan will cover so many sessions. It's harder as the patients get younger too. One thing I have found with cardiac rehab is those patients are ready to get back to work and get ready back to a more normal lifestyle. So sometimes they not forget, but maybe put that cardiac rehab on the back burner, where I think it's important to incorporate that. Some of these patients will work in like a factory setting. So it's a timed setting that maybe won't be as helpful to work around cardiac rehab. But if you can stress the importance of the cardiac rehab to the patient and get them to work with the nurses in different times that way too. Some programs will have earlier sessions or later sessions. But yeah, insurance is always can be difficult. So it's important to work with each patient and look at the plan, what the plan will allow beforehand.
Great. So we have a few more minutes. I have a couple more questions for both of you. So Dr. Shah, I'll start with you, and Dr. Maher, please chime in. At what point along the patient journey do you think we could tighten up the pathway to ensure better continuity of care? And I know each of you will speak from your individual perspective. So Dr. Shah, from the ER perspective, what do you think?
I think communication is key. Communication and in a speedy fashion. But as Chad mentioned, he was nervous, he was stressed, he may have thought he was going to die. So we're the first people that they interact with. And so reassurance and definitively communication with the cardiologist and with the cath team, and where does the patient need to be to get this done. And I think the communication aspect extends throughout their stay in the hospital. As I mentioned, there's anywhere from 10 to 12 people that may see them throughout their course of stay. And there really needs to be good communication between the patient and the clinicians, as well as the clinicians and the patient's family.
Great. Thank you. Dr. Maher.
Communication. I agree wholeheartedly with Dr. Shah that communication throughout that hospitalization, from the time they hit the ER going forward to the time of discharge, and then extending that beyond. Once we get back out into the outpatient world, communication is just as vitally important. We need to communicate with primary care or diabetes endo or lipidology, and then cardiac rehab if there's a dietitian involved. There's so many different aspects. I think one avenue that can always improve along with communication is I don't know if there's a way to streamline this, but looking at and figuring out how each system looks at managing separate entities. A lot of times cardiology will cover preventative cardiology, so that can include in some clinics lipid management, diabetes management, blood pressure control. And I think the communication can be improved with primary care or with other specialties as far as who is responsible for what and how can we best work together to get the end goal of cardiovascular risk reduction.
Great. So final question for you both. If you could change one thing about the healthcare system to help prevent repeat cardiovascular events from happening all the time, what would it be? So I will start with you, Dr. Maher, and we'll end with Dr. Shah.
One thing I would stress for each healthcare system would be, I guess, continued communication. I think that's so important. Continued communication and then patient education.
Great. Dr. Shah?
Yeah, I agree with Dr. Maher. I think, our facility does have a cardiovascular institute that sort of streamlines everything and keeps everything in one spot to make it easier for the patient. So I think that helps. And, definitely helping the patient feel less stressed. I think that the psychological impact is a big component that I think also needs to be part of the post hospital care as well.
Sure. So after this webinar, we're doing a report. We'll make sure communication is in big, bold letters. So thank you both for your time. I think this was extremely interesting and definitely very helpful for people who are just listening to you both. So thank you for your time. And now I'm going to pass it back to my colleague, Ryan, for the final panel.
Thank you for having me.
Thanks, Jasmine. And before we get started with our final panel, I have to say it's just so enlightening, to hear the patient experience on these kinds of issues, how healthcare works or doesn't work. Even from an anecdotal perspective, I think it's just so helpful. And the same is true for the clinician perspective. I think at least 3 of the clinicians speaking today are actually at work and taking time away from their practice to talk with us, which we're super grateful for. And these folks are frankly extremely passionate about these issues, and we're so thankful they'll take time away from life-saving work that they're doing to help bring light to these important topics. So thank you so much to them for joining us today. To bring the webinar home, we thought we'd bring in 2 cardiologists who have been in the business for a long time and have keen perspectives on these issues. And if you're familiar with Patch, you are familiar with these clinicians, these doctors. First, we have Dr. Dharmesh Patel, president of the board for our organization, the Partnership to Advance Cardiovascular Health. He's a practicing cardiologist in Mississippi, just over the border from Memphis, Tennessee. And second, we have Dr. Seth Baum, who is a past chair of the American Society for Preventive Cardiology. He's a preventive cardiologist who lives and practices in Florida. Thanks to both of you for being here with us today.
Good to be here.
Good afternoon.
So, Dr. Baum, let's start with you. We've talked about this in the abstract when we talk about rates of second events and the across the country how many rates of second events we have. But can you put a finer point on it for us, kind of drive it home? So you're sitting with a patient after they've had their first heart attack. So what I'm curious is, how vulnerable are they really for having another event?
Yeah, so this is an enormous issue, unfortunately. The patients who've had a single event are at extraordinary risk for another event, an extraordinary, actually imminent risk for another event. So you cited a statistic that was pretty alarming, but I'll just make it a little more granular. An individual who has a heart attack has about just under a 10% chance of having another heart attack in the next year. So that's within the next year following the first heart attack, and about a 10% chance of having the need for a revascularization, another stent or a bypass. It's such an important time frame for immediate and urgent intervention to do everything we can to lower cardiovascular risk. And without going on too long with this, I'll refer to Chad, who certainly exemplifies the optimal patient and the optimal medical care. He was cared for spectacularly, and he did everything right, and his wife was there by his side, which is perfect. But he, although it sounded good, got his PCSK9 inhibitor 3 months after the event. So June he had the event. It was not June, it was not July, it was in August that he got his PCSK9 inhibitor. Optimal treatment really would be getting that PCSK9 inhibitor injected before he leaves the hospital. So we have much work to do, and we'll surely discuss it much more during the remainder of this conversation.
Thank you, Dr. Baum. So, Dr. Patel, I have a question for you. A patient has a blockage, comes into the hospital. You place a stent, maybe 2, stabilize the patient. Do you think that people understand after they've had that stent placed that they're not fixed? Despite all your attempts to help people understand that the game has really changed for them, what percentage do you think leave that room despite your pleas of helping them understand and don't realize that they're not fixed?
That's a great question. And I think, that's probably a very large amount. I'm just going to guesstimate probably 30 to 40% think they are now, quote, back to normal, I would say. And remember from our colleagues, when people are in the hospital, they're in the emergency room, it really is a, quote, teaching moment. These patients are, quote, the most vulnerable during those times. these are the times where we really need to reinforce things like lifestyle and taking the right medicines, because these are the times that patients are most likely to adhere to the medicines. So with that being said, a stent, for example, it just basically fixes the acute immediate problem. But as we are all aware, it's just not simply putting a stent in that fixes, and Dr. Baum and I probably practice and preach this every day. It's prevention that's the key, treating the blood pressure, the cholesterol, the diabetes, the insulin resistance, the sleep apnea, the smoking, the stress, the diet and exercise. And I always end up by telling my patients this, Mr. Jones, did you get your car service? I say, Mr. Jones, where have you been for the last 3 years? He goes, well, I just thought I was doing fine. And I say, well, okay. Did you get your car serviced last year? And he goes, sure, I did. I go, well, why did you get your car serviced? He goes, well, because that's what I do. I say, well, that means your car is more important than your cardiac health, because you're more willing to get your car serviced than come and see a provider once every 6 months to a year.
Mm-hmm. So Dr. Baum, let's take this out a little more globally again. So, we have a lot of pressing issues when it comes to healthcare and then to cardiovascular medicine. And, just to name a few, at the top of my head, we talk a lot about these broad trends in diabetes and obesity and how that puts folks at higher risk for cardiovascular disease. The healthcare system right now is trying to figure out where telemedicine fits within standard of care. You have organizations that put a lot of focus on primary prevention and preventing that first event. And today we're focusing on secondary prevention. So my question to you is, how important is this secondary prevention discussion? We talked at the top about how, we know where these patients are. We know who they are. We know what to do with them. So, how important is the fact that we're not preventing those second events, in your opinion?
Well, if you just look at the numbers and look at the fact that cardiovascular disease still represents the #1 cause of death in the United States, and we're talking about people who have expressed themselves. In other words, these are people who have come forth and said, I am the person who might die from a heart attack or a stroke. And I'm the most likely one. I am part of that low-hanging fruit, if you will. It's immensely important. We have many hundreds of thousands of events a year, and among all these events, we have our highest risk individuals who are most likely to have another event. We should be doing everything imaginable to stop this in its tracks. And as Dr. Patel said, what we should be doing is really helping teach our patients about secondary prevention, the very wide array of tools we have, but as it pertains to lipids, which which is really the most important intervention we can make, and it's not just that I think that that's actually been well documented. We need to be expressing urgency about lowering LDL. We need to have the patients understand the urgency, the patient's significant other, because that's always critical, having a significant other in the room. And the doctors need to understand the urgency. Right now, it still feels as though LDL management is something that's important and necessary, but it could take a little time. And the truth of the matter is, it really can't wait. The sooner we intervene, the sooner we have benefit. So the utmost of importance in brief, Ryan.
Absolutely. So this question's for both of you, and I want to kind of dig into then, where we're seeing those. We're talking about the patient pathway, like where those bumps in the road might be, right? So I was talking to a cardiologist friend of mine who practices at Massachusetts General about this discussion, and she related to me, and I'm curious if you all agree with this or how you would qualify this, that there are kind of 3 inflection points where a cardiac patient's therapy is dropped or changed or missed, and those are these. One would be at discharge, so the patient doesn't have a clear understanding of the game plan once they leave the hospital. The second would be at cardiac rehab, assuming they can get cardiac rehab covered and they can actually access cardiac rehab. And there, that's where treatment medications are reviewed, but at that point, they may not be treated to goal. And then the third is really squirrely. It sounds like it's the follow-up appointments, and it's hard there because, talking to her, she was saying that, there's a lot of variation between practices and how soon cardiologists might see a patient after an event. They might see the primary care provider before they see the cardiologist again. It could be 3 months, 6 months, a year. Primary care might change the course of treatment in between. So I guess to make it easy to start, Dr. Patel, do you think that those, if we were to try to boil it down, those are kind of the three places you would say there could be bumps in the road, or would you add a fourth to that or take one away?
Yeah, I think those are certainly three of the major bumps in the road. But please remember, I think as the provider, it really is our job to communicate effectively to patients in a way that they understand what's going on. And, sometimes scientific lingo does not work in these scenarios. We have to make it simple. I have patients both from the city and from the rural area. It's key that we follow up with these patients. In our institute, we have to see these patients within 7 days. We have to. And, it's very important because if you look at something like congestive heart failure, we as institutes, as providers, as hospitals, we're all being judged on our quote readmission rates. 25% of patients who get discharged with congestive heart failure get readmitted in 30 days. So the point is, we have to do everything we can to prevent these recurrence of events happening. So yes, that does mean going through the medicines, making sure they bring the medicines on their first visit. And, unfortunately, a lot of the time we don't understand the issues these patients have. They may not be able to read. They may not be able to afford the medicines. Their transportation is far away. So these are all very realistic, real things that are happening. And this is where those patients fall through the cracks. They unfortunately continue to have events. And I would say generally in practice now, most providers really want to see these patients in the next 7 days. And I'll be honest, it's not the responsibility of the internist or the cardiologist. I think it's teamwork. We need to all work together. And especially when it comes to cardiac issues, I think they need to be seen within the first 5 business days of discharge.
Dr. Baum?
Not much to add to the 3 points of inflection and where we have to intervene. I guess I would say that it is a team effort. We do have to enlist, the patient as well. The patient really needs to be very deeply involved, as Chad is. And I want to reinforce just one other thing, which is that the significant other concept. Too often patients come in alone. And when you're sitting in a doctor's office, it's a very frightening event. And sometimes you blank out and you don't really hear everything. And you walk out of the room, you go, oh my God, what just transpired? It is always good to have a significant other, by your side. So I would encourage that, and I would sort of bake that into any materials that are developed that are patient-facing materials, the significant other concept.
Mm-hmm. Let's, I think that's a great, for any of the patient advocacy organizations that are online, something to really think about, post this event is how we can maybe create some of those materials for patients and for their significant others that are with them in these meetings. I think that's really good. And honestly, listening to Chad's story, the thing that impacted me is how aggressive he was about his own health. He was going to play the quarterback and make sure he and his wife play the quarterback with his cardiovascular health post-event, and they really took it in their own hands.
So Ryan,
yes,
yeah, I would just add, as we've discussed in previous settings with regard to patient advocacy issues, the patient does have the loudest voice, and the patient is the one who really has to take this to heart, pun intended. And say, this is my issue. I need to be my own advocate. Now, when I mention the significant other, that's critical as well. But really, this is going to fall on the patient. So we need to empower the patient. We need to give the patient the tools necessary to understand what's out there, what the patient needs to look for, what maybe the patient's not getting. Really very, very important to educate the patient.
So we've got just a few minutes here left. I want to ask a really important question. Dr. Baum, why don't you take this one first, and Dr. Patel, you can follow up. But pretty simple. Why don't we treat people's cardiovascular risk factors more aggressively after an event? Like Dr. Baum, you just mentioned, it took 3 months. Now that's probably with Chad's PCSK9 inhibitor, and that's probably an insurance issue, an access issue, which we're well familiar with that, the PCSK9 space. But can you point to any other reasons why we don't treat people's cardiovascular risk factors more aggressively after an event?
Yeah, so I mean, there are many variables, involved here. One of the issues is I think we have not really taught the medical people. Let's call them doctors, some nurse practitioners, perhaps. We've not taught clinicians about the urgency of something like managing lipids. In the context of an event, if we look at that event and say, well, within a year, there's going to be a 20% recurrence rate of some sort, a bad recurrence. Having a stroke, for example, would not be a good thing to have after that heart attack. Anyway, that's a really high probability of an event. Well, so there should be this sense of urgency that we need to do things, and yet lipids kind of fall out of that. I think partly because of some of our societies, in fact, that maybe our guidelines are very complex and intricate. Instead of just saying we got to hammer this down and get LDL as low as possible, something as simple as that, which would send the message. We have all sorts of algorithms and structures and when to do what. So part of it falls on us, I believe, and part of it's just an inherent nature of some of these types of risk factors, that they don't seem as though they're that dangerous. A blood level of something, for example.
So it's like, was it losing the forest of the trees or something? So it sounds like.
Mm-hmm.
Dr. Patel?
I agree with Dr. Baum. I think I'll take the opposite, since he talked about the provider aspect. Let's talk about the patient. As Dr. Baum said, 40% of patients feel great the day before they have a heart attack. So, quote, they feel fine, their blood pressure's high, but they feel completely normal. So that's one issue. And then as a patient, remember, there is this thing called pill fatigue. And a lot of my patients are resistant also to taking the 8th and 9th and 10th medicine, because, if you have a diabetic who has CAD, that patient ultimately may end up on 6 to 10 medicines. It's possible. So I'm not blaming the patient, but I'm just taking a different angle, since Dr. Baum talked about the provider angle. It's a team approach. And so there are factors from the provider, physician aspect, access aspect, but there's also limitations from the patients about number of pills. Which one do I take, Dr. Patel? I can only take 5 pills. Just tell me the 5 that you can give me, because I don't want 8, 9, and 10. So these are all realistic variables that come into play about why, quote, CAD has not been treated more aggressively. Now, remember one thing, as a general society, I'd like to say that we as a society, it's the first time in history that the older population may outlive the younger one. I don't think it's all because of just medicines. It's because the younger population is becoming more and more less active, insulin resistance, and diabetes is becoming an epidemic.
Mm-hmm. Mm-hmm. So to wrap this up, the 2 hard questions, the big questions I'll throw at you guys. We're not going to be able to fix the world's problems in one webinar, but that being said, Dr. Baum, if you could pick one thing right now that we change to help improve this continuity of care issue, the secondary prevention issue, what is that one thing?
Yeah, so I'd love to see a really good patient-facing materials, an infographic of some sort of a device whereby when a patient comes into a hospital, it's available. They see this. The spouse takes it home, looks at it, goes, oh my God, we've got to deal. We've got to deal with this, act on it. It's urgent. And it would help empower the patient to understand the risk that the patient's facing, to understand the opportunities to avoid that risk, and the need for being an active participant in avoiding that risk. So if you could create something like that or get that out there, I think it would be very, very helpful.
Okay, so Dr. Patel, before we can get, make this this infographic or educational piece, in the meantime, what's one big piece of advice that you would give to current patients, setting out on this next leg of the patient pathway after they've had an event? What would you encourage them to do?
So absolutely, Ryan, how I approach it, say, look, Mrs. Jones, you've had a cardiac event. We together are going to try to never let that happen again. And I say, heart disease is not a cancer. It's primarily a preventable disease state. So I emphasize that we're going to work together. I emphasize the fact that this doesn't ever need to happen again, and be positive about the different aspects like the medicines, compliance. If they have any questions, access is very key about getting to the provider. So it can be done, absolutely. And I tell my patients, if we work together, I can almost guarantee this will never happen again. And people like that. But of course, the provider has to put skin into the game. And more importantly, as Dr. Baum said, the patient also needs to believe in it. And then if he believes in it, he is more likely to take medicine and be compliant moving forward. Because remember one point, I hate to say it, up to 50% of patients stop taking their statins after a year. So there's obviously this misconception, and we as providers, we all need to work to making sure that these patients do take their medicines and they come on a regular basis.
Mm-hmm. Well, Dr. Patel, Dr. Baum, thank you so much for your insight. It's it's always a pleasure to talk to you. So thank you for joining us. Appreciate it.
Thank you
for being here, Brian.
It's fantastic to come away from one of these things and feel like there's some action items, and I do feel like we've got some of those now. It's clearly a really hard nut to crack. This is a really complicated, difficult issue, multiple players that are going to have to change behaviors somewhat. But I'm glad that we were able to host this discussion and suss that out a little bit. So this has been fascinating. Can't thank Chad enough. Can't thank our clinician guests enough. Thank you so much for being here. And to our audience, thank you for joining us for this discussion. This will be posted to our website in a couple of days if you'd like to share it. We'll also be using this webinar to inform a report, as Jasmine mentioned, that we'll be releasing in the coming weeks about this topic, so be on the lookout for that. And finally, I want to take the opportunity to invite you to mark your calendars for July 15th for our 4th annual Cardiovascular Health Policy Summit. You can register for that by clicking the events tab on our website just above the webcast. There's a lot going on in health policy and in cardiovascular medicine, and we'll be releasing topics and speakers for that event very soon. Thanks everyone for joining. Be well. Happy ACC week. Thank you.